talk. Now allow me to introduce our second esteemed speaker, Dr. Mansour Alfayez. He's a consultant adult hematology at the Cancer Center of Excellence. So he is also a translational researcher, having done a master degree in tumor biology at Georgetown. He completed his hematology and leukemia training at MD Anderson. So today, Dr. Mansour will try, and I'm sure he will be successful, to show us how we can emerge through an MDS by showing some early clinical trials and some translational aspects. The microphone and the podium is yours.
Thank you, Dr. Mukadi, and thank you for the organizing committee for their kind invitation. The topic I'm assigned to today is myelodysplastic syndrome. And there is a lot of things to talk about in MDS, which means there is really no magic bullets here, unfortunately, and it has been stagnant, at least in the high risk, for a while now. Those are my disclosures. Now, before we start discussing more of the nuance, just saying that we have the two classification now, and the discrepancy between the two in assignment of the cases is around 50%. So 50% of the time you will have a different labeling if you use an ICC versus a WHO, which is a problem if for clinical trials and for physician if they need to speak the same language. And I think probably a unified diagnostic or a unified classification system is going to be the case, and this is one of the reports that has been done on 7,000 cases from the MDS consortium. Just before jumping, also just worth mentioning the IPSSM, which came after the IPSS and the IPSSR, and which integrate the molecular profile. So it has around 31 gene. In addition to the cytogenetics and the cytopenia and the blast count. So clinical features, so integrating the IPSSR with the molecular data, and it's classified the patient to 6 cohorts instead of the 5 in IPSSR or 4 with IPSS. Now, in general, in MDS, we talk about low risk and high risk, and in the low risk, we always talk about quality of life, transfusion dependent. But I think the field is start to move, and we get a sense that in low risk MDS, now more talk has been done about survival, about progression. So slightly we are changing the way we view low risk MDS. In the high-risk MDS, I think survival and the struggle with survival is still present, and the progression to the AML. So, drugs approved in MDS. So we have the azacitidine and the cytopine in the early 2000s with Revlimid or lenalidomide in isolated 5q deletion, low-risk MDS. More recently, in the last 5 years, we have luspatercept, which is approved in the second line initially after failure of APO or non-eligible to APO. And more recently, in the 2023, it was approved as a first line after the COMMAND trial. Oral decitabine is not currently available in Saudi, but it has been demonstrated to at least be bioequivalent. And we'll talk about the trial in those in a minute. Ivosidenib is approved. Now the approval is as a single agent in relapsed refractory MDS, and it was approved based on like less than 20 patients actually. But it is approved, and it should be available for those patients. Imetelstat is the telomerase inhibitor, which is the latest addition in the low-risk MDS. So we have most of our medication is really targeting into either the low risk, you're targeting cytopenia, or high risk, trying to with the endpoint being an overall survival. So in the low risk MDS, we'll just speak a little bit about predictive response, medalist commands, and IMerge, and then we'll go for the high risk MDS. So just to get a sense, what are the issues in low risk MDS? And you can see the cytopenia is usually the risk, the anemia is usually the majority of the problem. and it's been transfusion-dependent anemia being the majority of a problem in low-risk MDS, around half of the patient. And then neutropenia and thrombocytopenia come after that. Now, if you look into what are the causes of death in MDS, yes, the progression to AML in low-risk MDS is low, but if you look into it in a total, you cannot escape the thought that it is in part at least related to MDS, whether they die from infection, which is you can see in the bottom figure here. So they die from infection, they die from bleeding, they die from progression. So eventually they are at least patient dying from MDS. And for that, I think, we start thinking about switching or shifting our focus from just transfusion independent stuff like that to actually more hard endpoint of survival. So predictive response to EPO, one of the very interesting reports just reported maybe 2 or 3 weeks ago in Blood, and I'm not sure why the referencing is here. It's by Riddle, 2025 Blood. So the predictive response for EPO in low-risk MDS, and this is looking through a molecular and gender lens. So it's actually make a difference if you are a male or a female, and that's because some of the very, especially the cohesion complex, like a STAG2 mutations are they are X chromosome, so and they are frequently mutated, and it seems that there is a different pattern of response if you are a male or a female to EPO based on those things. So this is an interesting response stratification. This is beyond the EPO, more than 200, less than 200, or 500 alone. So integrating the IPSSM, the molecular, and the gender, and in addition to the EPO level. Medalist this is what led to the approval of luspatercept in the second line. So it was EPO refractory relapse or EPO ineligible, so the erythropoietin level was more than 200. And they randomized to versus placebo as a phase 3 trial. And you can see here it demonstrated superiority, and always the magic number in MDS for some reason is 38%. So the endpoint was 8 weeks transfusion independence in the first 24 weeks, and the trial met the endpoint. Side effect wise, there is not much side effect except the fatigue, some of the patients reported, but beyond that, and there is the hypertension. Some patients will need to increase their blood pressure medication. And be careful, when you overshoot above 11, you have to either dose reduce or space out the drug. With a 6 years follow-up, you can see the duration of the response duration is actually long-lasting. So patient who met the 8 weeks primary endpoint, 40% of them will actually sustain more than a year of transfusion independent. And those who met more than 4 months, like 16 weeks, two-thirds of them will sustain it for more than a year. So there is a long sustainability of the response. It's just not meeting the endpoint, and they lose the response. The commands, they looked into it as a first line in erythropoietin eligible, so this is randomized against erythropoietin. And you can see also that the trial did meet its primary endpoint of 8 weeks transfusion independent, and combined with 1.5 gram increase in the hemoglobin. And what is more interesting, if you look here, if you look into the group of 3B1 mutation status and you look into the non-mutated, you don't really see much of a difference between luspatercept and EPO. And the same thing with ring sideroblast, which is kind of an overlapping population. Those patients who don't have that mutation, usually they don't have ring sideroblast. So you don't see that advantage of luspatercept, and then the question comes, if you have a patient who is S3B1 negative and ring sideroblast negative, what is really your best treatment option? And I think that's the question still open. Now, if you look into the commands, the long term of commands follow-up, and you can see that the transfusion independent sustainability is higher with luspatercept comparing to erythropoietin. You can see here, you can have 30% at more than 1.5 years comparing to 13%, so that sustainability is higher with luspatercept. But I think what was more interesting in this analysis, although this is not really an endpoint implemented in the trial as a primary endpoint, but it is a hallmark analysis, not like an intention to treat analysis. But there is some separation of the curves on a landmark analysis that was done at 36 months. So I think that's interesting, and I think this is where the shift that is being done in low-risk MDS toward the survival is starting to emerge. IMerge, which is the Amilostat trial. So this is EPO MDS transfusion, low-risk MDS transfusion dependent, who failed EPO or non-eligible to EPO, so they have a high EPO level, and they were randomized to either placebo or Amilostat, and you can see the primary endpoint, and again, the magic number of MDS is 38, 39, in that range. So you can see the 8 weeks transfusion independence around 38, and you can see also the 15% in placebo, which is interesting, and you see that also on the commands. If you remember the commands, it has a 13%. So this consistency in MDS is a bit interesting, and you can see that increase in actually hemoglobin is quite significant. The median increase is around 2.5 grams. The delta between the drug and the placebo. What is more interesting, I think, in this drug, it might have a disease-modifying effect. So you actually do have the driver mutation, which is the most common in low-risk MDS, is F3B1, and you can see a significant decrease in the allelic burden of the mutation. So this drug might have a disease-modifying, and we did see at least in the MF study. So there was an MF study a few years ago on the same drug, and there is a latency in the tail of the curve, a probable survival advantage with this drug. So there might be a disease-modifying property here. One of the problems, or the problem with actually this drug, is cytopenia. So it's thrombocytopenia and neutropenia. Usually in the first 3 cycles, when you have to probably support the patients with growth factors during this time. In the trial, there was no mortality because of those cytopenias, but it's worth mentioning, and it is actually important to deal with. Now, the drug, unfortunately, is still not available here. So, and I'm trying to get one patient on it, and so far I haven't been successful. Now, one of the things that are more interesting in MDS is, can we move earlier? We treat patients who are not yet transfusion dependent, and see if we can modify their natural history or natural disease course, being a transfusion dependent or progression. One of those trials is Element, and it's been recruiting, and you can see here survival and progression to MDS. So there is an endpoint. So there is a change in the concept of low-risk MDS, and switching to focus more, or at least have some focus on hard endpoints like a survival and progression. How about combining erythropoietin and spartacep? This is a preliminary report, but the trial I think is anticipated to have reported maybe next year, and I think that will be very interesting to see, and I think probably it's going to be a positive trial. How about doing max dose of luspatercept instead of, starting with 1 mg and then 1.3 and then 1.5 and 1.75? What about starting with 1.75 and then, decreasing as you go along? And this is one of the trials that looks into it. Now, I don't see the responses that much different, actually, but I think in the relapsed refractory setting, it might be actually interesting to see, because I think the responses here is slightly better than anticipated. In acidinib in low-risk MDS, now we have data on acidinib in high-risk MDS. The low-risk MDS data is very limited, but we have here one report from the German group, and it's a cohort C here. Oh. It's cohort C here, and you can see a 55 complete response, which include, complete transfusion independency. So in patient, this is very rare to actually have, because once you get the IDH, usually you are at the high risk or progressing to an AML. So it's rarely seen in a low-risk MDS. Centria, this is a Spanish report, about Revlimid in transfusion-independent MDS. Again, this is early intervention. And they do a low dose, 5 milligram. And you can see here, it delayed the transfusion from 1 year with a placebo to 5.5 years with Revlimid. And it's actually, interestingly, you get actually a full cytogenetic response in more than 2/3 of the patient. So I think early intervention MDS is something we are getting the idea of, and maybe the future will also carry the early intervention in CKS and CHIP, and we'll see how that will go. Just not to forget, combination with G-CSF or filgrastim in MDS is actually active when you combine it with EPO. So it's just not to forget the old thing. Also, combination of lenalidomide with EPO, it's better than lenalidomide in subsequent line of treatment. TPO mimetics in high-risk MDS, we don't use them because they push the patient to progress into AML, and they actually have a lower survival. But in the low-risk MDS, we don't see that, but they are not approved, so the usage here is off-label. Iron load in MDS is a problem, and you can see from the top curves that the more transfusion the patient has, the worse the outcome, the survival. And the bottom curve here, you can see the ferritin being demarcating the survival. So there was this trial that had a poor recruitment, but eventually the event-free survival, which is like a cardiac failure, a liver failure, or a progression, was worse in patients who are not chelated compared to those who were chelated. High-risk MDS, we have the AZA, the decitabine, oral decitabine, ivosidenib, and the Verona. We'll talk about Verona. So AZA, just one slide here in AZA. Now the AZA 001 never replicated this results, the 24 survival, because we have all these registry trials with a large number of patients, and you are getting around 12 to 16 or 18 months. So the initial trial was really never replicated, which led to the approval. Decitabine, this is approved again. Those are old trials, but the new one is, which I think interesting. So this is a bioequivalency studies. So they have two sequence, one with IV, starting with IV and switching to the oral, and the other one is starting with oral and switching to the IV, and it's a bioequivalency, so they get into the methylation pattern, the difference, the drug concentration, and there was no difference between the IV and oral. But I think what was interesting to me is this median survival. I think this is a very interesting survival, and I don't know if it is a signal or because this is higher than we have seen with any of the HMA. Again, we cannot do really, cross-trial comparison, but I think this is a very interesting. Ivosidenib was approved in the high-risk MDS based on this report of, it's actually 19 patients included and 18 patients evaluated for response. And in the relapsed refractory setting here, you see around 15% CR rate, which is completely complete disappearance of, or blast less than 5% with complete resolution of transfusion dependency. And in the first line, you get around the 48%, which is similar to what you actually see in A. Actually, slightly higher than what you see in A. Oral decitabine with venetoclax. This is a retrospective report from the MD Anderson group, and there was no significant survival benefit when you add venetoclax to oral decitabine, and the survival looked to be the same. But I think what is interesting, or what we have been waiting, was the Verona trial. So AZA versus AZA-VEN, and people were waiting for this trial, and it was reported this SOHO a couple of months ago, and we still don't have the full publication. The group's balance, it seems to be well balanced, and here is the problem, I think, or what we did not expect. The survival is the same. The curves are overlapping, and there was no survival advantage of adding venetoclax in high-risk MDS. This is looking into stratifying by the response according to univariate analysis for the response. We would love to see it for the survival, but it wasn't presented. Now, you have a higher responses with VEN. It just does not impact the survival. So what is next? Unified classification. I think this has to be done. Lower risk MDS, we will start aiming towards survival. Early intervention before the patient becomes transfusion dependent. Combination treatments, and how do you sequence your treatment? And where to fit the transplant, which I haven't talked about here, but where to fit the transplant in low-risk MDS, because we are not really transplanting those patients, and is there a way to isolate those patients who need a transplant? High-risk MDS, post-HMA is just a problem. We really have nothing to offer at this point if they are not transplant eligible. Targeted therapy, I think we are going to see more and more of those coming into the MDS, but I think MDS is not AML, and we really have to understand, and just keep borrowing the drugs from AML and put them in the MDS. It doesn't work. It's a different disease. And TP53 is, as is the case in AML, is actually an issue to be figured out. And thank you. With that,